Hey guys, it's Gianna, Midwifay. Today, in the next installment of my labor induction series, we're going to talk about being induced for pre-labor rupture of membranes, or PROM. In this video, we're going to talk about the definition of PROM, what it is, how often does it occur, what are the risks of this, what is this linked to, what does it mean for your labor experience, and the options of being induced for it or not. So let's get into it. Always, I want to encourage you, please like this video, subscribe to the channel. It really helps me know which videos you guys like and what other content you want. So please go ahead and like and subscribe if you haven't already. Alright, so PROM, P-R-O-M, is defined as pre-labor rupture of membranes or premature rupture of membranes. So what that means is when your water breaks before the onset of true active labor with contractions that are dilating your cervix. It's important to distinguish that I'm talking about full-term PROM here. I'm not talking about P-PROM, which is when you have preterm premature rupture of membranes. So I'm talking about being at least 37 weeks when this happens and when your water breaks before contractions start, before your cervix starts to dilate. Now, to explain when your water breaks, you can go watch my What Happened My Water Just Broke video, and in it I had the same little sac here describing what it looks like when your water breaks. Okay, there's the placenta, there's the sac, the baby's in here. And so when your water breaks, that's when there is a break in this seal somewhere, whether it's in this really old used one, it's here on the side, or if it's more down here, the sac breaks and fluid starts to leak. However, I think it's important to explain that there's actually two sacs going on when you're pregnant. So when I say two sacs, I like to explain it to people like a boiled egg, okay, a hard-boiled egg. There's the hard white exterior, and then there's that filmy part on the inside. And when you crack open the egg, when you're peeling it, usually both come off together, but if not, there's that filmy layer on the inside. So not exactly physiologically accurate 100%, but similarly, there's a chorion and the amnion, okay? So the amnion is what you're thinking of, the sac. That's this part that's around the baby, filled with fluid and water, big gush, lots of fluid. There's something also called the chorion, okay? And I can't really depict it here, so I'll have an image. And that is kind of a thin layer that lines the inside of the mom's uterus, okay? So the chorion and the amnion are really the two sacs that make up what we can call the amniotic sac when you're thinking of your water breaking. So sometimes when PROM happens, people define it as high leak, which means maybe just one of those two layers broke, more commonly the chorion than the amnion. However, that's not always the case, and there's not really a way for us to know at diagnosis which one broke or if it was just one of the two sacs. So how often does this occur? Data supports that approximately 8% of women experience PROM as the initiation of their labor start. 8% is equitable to about 1 in 13 women. Data also shows that of the people that PROM happens to, about 80% will go into labor on their own within 12 hours, and 95% or so will go into labor on their own within 24 hours. So again, going back to that Did My Water Break video, how do we determine if your water broke? How do we diagnose it? What it requires usually is something called a sterile speculum exam. So you call your provider, say, hey, this is what I experienced. I pop and a gush, or slowly I'm starting to leak fluid, or my underwear is wet and it keeps getting wet and I'm not peeing. And so then you come into the hospital or the office. Sometimes you can do it in your office as well. And we do a speculum exam where we take a look inside of the vagina, see what fluid we do see, and then we swab it. So there's a couple of different kind of quick tests we can do, but the most reliable is for us to put the swab under the microscope to look for ferning. I'll have a picture here of what ferning looks like, which is when the amniotic fluid salts dry. It looks like a fern, the plant. And so that's how we confirm that your water is broken. Once we've determined, sure, your water is definitely broken, there are some considerations we need to take in discussing next steps here at this point. We likely will check your cervix to see if you're dilated at all. Now, especially if you're in the hospital environment, the triage environment at this point, you may be hooked up to the external monitors where we're looking at baby's heart rate as well as your contraction pattern. And if you're super comfortable, you're not feeling contractions, we're not picking any up on the monitor, we may decline doing an exam. We may say, it doesn't look like you're having any contractions, you're not feeling any contractions. When I did that speculum exam and looked inside, your cervix didn't look like it's dilated, so I don't really feel the need to check you. But some providers might recommend getting a cervical check at that time. So now we know your water's broken, we check your cervix, we find that it's closed or maybe half a centimeter dilated or one maybe, but really firm, really long, really high, not showing other signs of labor. That will help us with this diagnosis of PROM, that your water broke, but before labor has started. So why does this happen? Of course, right? As if everything in science and medicine, we don't always know exactly why things happen. Some theories are, the physiologic weakening of the sacs. Towards the end of pregnancy, the sacs are supposed to weaken, they're supposed to break, right, with strong regular contractions. So typically that happens with labor. We like to see that. So there is just the argument for it's normal physiology towards the end of pregnancy for those sacs to weaken to be able to break with labor. Some other reasons it can happen are infection, either vaginal infection, things like STIs, things like common bacterial infections in the vagina, bacterial vaginosis or yeast infection. So that can be reason why your water breaks before labor starts. Other reasons can be those cervical checks. If you're not sure what a cervical check is, go watch my All About Cervical Exams video. But a lot of OB practices start checking your cervix regularly at your end of pregnancy appointments when it's not necessarily needed. So sometimes when you've had your cervix checked regularly every couple of days, the studies show that that does increase the chance of PROM. So now that we know that your water is broken, we know that you're not really dilated, you're not really contracting, here are some considerations to think about. Firstly, GBS status. Your Group B strep is a culture that's offered around 35-36 weeks of pregnancy. It's a swab of the vagina and the rectum to look for bacteria. I'll do another video on that as we move further in the Pregnancy Informed series, which I'm really excited about. But basically, if that's positive, the recommendation is for you to receive antibiotics in labor or when your water breaks. So if your GBS is positive, the recommendation is going to be likely for you to receive antibiotics from the time your water broke, even if it's before contractions started. If your GBS was negative, then that means we don't need to worry about the antibiotics, and it gives us a little bit more leeway on kind of management options of what to do now that your water's broken. Some other considerations to keep in mind at this point is fetal positioning. Now, anytime we think labor is starting, your water's broken, it's always important for us to know if this baby is cephalic or not, especially in the hospital system. Usually non-cephalic babies aren't offered vaginal delivery, so we definitely want to know, okay, is this baby head down? That's super important. So I'm going to assume we've confirmed that when we confirm that your water is broken and checked your cervix, okay? So, but now that we know that this baby is head down, we want to consider what position is this baby in the pelvis. We can't always determine this by vaginal exam, especially not if you're not really dilated and I can't really feel the sutures on the baby's head that help me know what direction baby's facing. But we can do this kind of with external Leopold's maneuvers where we feel the baby externally based on kind of where you're feeling some sensation. So let me talk about positions. The ideal position, optimal fetal positioning, is for the baby's back to be against your front, okay, like this, and the baby's head is flexed, and to come down through the pelvis this way, okay? This is the way that we want the baby to come down and through, okay? However, babies can be going into the pelvis any way, right? Sideways, which is called a transverse position, this way, which is called an OP, occiput posterior position. They could be transverse, but something called asynclitic, where they're kind of a little tilted a little bit. So again, there's no way for us to truly know what position the baby's in other than head down, but based on experience and a variety of things, we can kind of see if baby is a little bit malpositioned in there. And I say that because sometimes, I will say clinically in my experience, when I see PROM, I sometimes see, oftentimes really, that baby is in not an ideal position, not that optimal fetal positioning. So fetal positioning is a consideration that we have definitely when diagnosing PROM. Let's talk about your options. What are your options if it's been confirmed that your water is broken, you're not quite in labor yet? What are your options? Again, with or without the GBS status. If you're GBS positive, the recommendation is going to be for you to get antibiotics, which means definitely being admitted to the hospital, at least for the antibiotics, okay? If you're GBS negative, there's a little bit more wiggle room there. Now, we'll first talk about expectant management, which is kind of that watch and wait, do nothing approach. We'll look at the data of both. Again, data shows that about 80% of people start having labor contractions within 12 hours of PROM, and 95% of people start having labor contractions within 24 hours of PROM. So if you're low risk and normal and baby's head down, you know, it's in your favor, honestly. 80%, 95%, more likely than not, you're going to start having contractions within 12 or 24 hours of your water breaking. If you choose this 12 to 24 hour wait period, depending on your provider and your hospital and your GBS status, you may do this at home. You may go home with some special instructions. Usually we say nothing in the vagina, don't get in the bath, don't put any douching or anything up there, no intercourse during this time. So go home to kind of await labor, come back to the hospital at a defined point, maybe 8 hours, 10 hours, 12 hours after your water broke. So that's that expectant management piece, either done in the hospital or done at home, waiting for labor contractions to start. Active management is always going to be doing something medical to keep things moving. And in this case, active management option is to induce, right? That's why it's in the induction series. To either induce with Pitocin or induce with prostaglandins, which are kind of those early cervical ripening agents. There's pill prostaglandins as well as vaginal insert prostaglandins. During my What is a Labor Induction video, I talk a lot more about the pharmacologic, the medications that we use for an induction. So I'm not going to go all into that. I'll just go into kind of the data that talks about using prostaglandin or Pitocin. There's actually not a big change in how long labor is if you use prostaglandin versus Pitocin in case of PROM, but data supports the use of medications to initiate labor. There's going to be a shorter time between PROM and delivery versus if you did that expected management, which makes sense, right? If you wait 12, 20 hours before starting medication to get things going, that adds 12 or 20 hours to the labor course. So you can choose either prostaglandin or Pitocin, whatever's offered at your facility, what your provider recommends, to start having contractions and getting that cervix dilated. Now let's go over the risks. You know, what are the risks of PROM? The idea that your water breaks so early in your labor course obviously carries the risk of a prolonged labor, right? A long labor. And what is the risk of that? The number one risk, especially once the water breaks, is infection. Infection to mom or to baby. So the biggest statistical risk is chorioamnionitis or endometritis, which is infection of that chorion membrane in mom's uterus, or endometritis, where that infection truly goes into her uterine muscle tissue. That's the biggest increased risk. There is also increased risk of NICU admission with PROM. So again, there's an increased risk of baby getting an infection. I want to point out though that data says increased risk of NICU admission, and that's often because of hospital policy and procedure that says if mom has a fever at any point, if mom's on antibiotics at any point in labor, or if water's been broken for this long, you know, it is automatically a policy that the neonate be admitted to the NICU. However, data does not support the fact that more confirmed newborn infections happen after PROM. So I think that's important to recognize. Other important things to recognize are what does not increase with PROM. I think a lot of people think this, but data does not support. There is no increase in C-section rate with PROM, even if you choose to do that expectant management, okay? So I think that's super important. I think people in the hospital might tell you, you need to start Pitocin now because you're gonna have an increase in C-section rate if you wait. It's not true. Data doesn't support that. You don't have an increased chance of C-section if you choose to do an expectant management picture word where you wait a few hours before starting your induction. So C-section rate does not increase, nor does that perinatal mortality rate. Obviously, devastating outcome for mom and baby and a whole family is if a baby dies as a result of this management decision, right? So it's important for you to know that when going into making this decision and having this discussion with your provider on if you want to start with expected management or right away get going on induction. When discussing options for induction in PROM, again, our options are going to be prostaglandins or Pitocin, and usually we like to avoid anything vaginal. So even the prostaglandin gels or inserts, which can be done vaginally, data shows that that will increase the chance of maternal or infant infection. Also, any mechanical dilators, so the ripening balloons, the Foley balloon, the Cook's catheter, whatever your hospital facility has. Generally, we steer away from those methods when your water is broken because of the increased risk of infection. So now that we've kind of gone through the definition and how often it occurs, risks, benefits, management options, let's talk about my recommendations. My first and strongest recommendation is to talk about this prior to labor start. So as you're going through your birth plan and discussing things in that third trimester with your provider, talk about, hey, what happens in the case of PROM? What's the hospital policy? What's your recommendation specifically as a provider to really get a feel for what they would recommend? You know, some providers are comfortable with expectant management and even in your home, and others, honestly, are just more medicalized. They're like, no, it's not something I offer my patients. I wouldn't offer for you to leave the hospital. I would say that you have to stay here and start Pitocin immediately, right? So super important to talk about this in those latter weeks of your pregnancy before labor starts so that you can kind of know what your hospital's policy is and what your provider's recommendations would likely be in this scenario, so you can be prepared. My other recommendation, which I will talk about more in that cervical check at the end of pregnancy video, is consider limiting those. Again, many OB providers in the medical model start checking your cervix around 36, 37 weeks at every appointment. When it's not necessary to do so, they're uncomfortable. Data does show it does increase the chance of this PROM occurring. So, you don't have to have your cervix checked at every OB appointment. It doesn't tell us a lot. It doesn't let us know if you're going to go into labor or not. So again, something to consider is limiting those cervical checks that happen towards the end of pregnancy in your OB's office. All right, that was it. That was all about being induced for PROM. I hope that helps. It's, again, a super common scenario that I see people come into triage with and have a lot of questions about. So I hope this video was helpful. As always, please like, subscribe, comment. Let me know what other interesting topics you guys want to talk about. Okay, I'll see you next time. Bye-bye.